or on a microscope even, comparing it to an endoscope, it's just, yeah, it was a game changer for me when I first started using an endoscope in my practice and we started developing the iClearScope. Now we're on to the right ear. This ear the patient felt wasn't as bad. The patient noticed after I cleared the left ear that this ear actually was bad, but when the patient attended, because the patient's comparing one ear to the other, he felt the left ear was significantly worse, and he wasn't really aware of a blockage in his right ear until I cleared the left ear, and obviously the patient could notice the difference. This ear was actually a lot more challenging. The ear canal was a bit more narrower, but the wax was a lot more adhered to the ear canal. There's a lot more dry skin adhesions here, so it took a lot longer to remove this. So just using a Zollner suction probe, you can probably tell that the ear canal is a bit more slit, it's a bit more narrow. Everyone's ear canals are more, you have got an oval appearance like a rugby ball, or if in American football. It's like kind of an elongated circle. But with this patient, that elongated oval, it's a lot more stretched. It's from the width it's narrower, but the length with the height is higher. And it's potentially one of the reasons why the patient's getting a build-up. It's the first time the patient's attended here, but he did mention that on a yearly basis normally needed his wax removed, and I think it's been a couple of years, so he's way overdue. So I'm just persevering at the moment with the Zollner suction probe. Probably removed about a third up to half of the ear wax, so all the lateral wax near the entrance I've removed. I'm just trying to pull this through the narrowing, so just like the left ear, so this ear canal also has two narrowings, one about 1 centimetre into the ear canal and the second about 0.5 centimetre away from the eardrum. So I've just tried to go in with the forceps, but what the forceps actually does, when I'm trying to get a grip, it can also at the same time push some of the wax further in. So you've got to be very careful. We don't want to be pushing this wax further in and causing more of an impaction. So just removed a bit of dead keratin off that wax. It's very dry. So I've decided to use an ear hook. I have to get the right orientation. There's not much space in the ear canal because it's quite narrow. So the L bend I've rotated so it's facing upwards superiorly to the roof, and then once I'm in, I'm twisting this ear hook, trying to embed it within the wax, pulling it out. Unfortunately, it's just dissecting it. It's not really helping much. So because I've dissected it, cut it into small pieces, I've just gone back in with the Zollner suction probes to see if I can wriggle it out. You can see I'm really tugging at this. It is some of the dry skin and wax is coming, it's separating from the main body. So that there that I'm suctioning, it's not actually wax. It may look like wax, but it's dead skin, it's dead keratin. You can see the ribbons actually of dead keratin that's shedded, the different layers. You can probably see it. You'll see this, the ribbons of this dead skin, and it's all coiled around this wax. So there is wax there in the core, in the centre, but around it you've got keratin. So I've decided to use a Jobson horn. Not much space. A Jobson horn, the surface area is a lot wider than an ear hook. I can just about insert it, and I've got a little bit of this dry wax out, but not a lot. But it was not possible to get that Jobson horn any further than what I did there. So just using the forceps again, you can just there was a bit of an opening there on the anterior canal wall, and just managed to pull some dead keratin out. There's another sheet of keratin. Unfortunately, each ribbon of dead skin keratin, it's removing one layer at a time. Ideally with the forceps, and with the Jobson horn, and also with the ear hook earlier, you wanted to extract a big solid mass of dead keratin wax out in one go, but in this case it wasn't to be. So I'm just persevering again with some suction. And you can see I've got a bigger piece of keratin at the top. I think this video is great to illustrate that sometimes the instrument you think is the best instrument actually in practice is not. And quite often we have to use a combination of instruments in conjunction with each other. They all support each other. When I first got trained in doing clinical ear care, I was only trained in microsuction. It was only when I decided to develop the iClearScope. So just a bit of background. First got trained. So audiologists in the UK don't get trained to remove earwax as part of their core training. I think that's true to say with most audiologists around the world. It's an additional skill that audiologists over the last decade or so have acquired, and it makes sense. Audiologists are the best people to remove wax because we are looking in people's ears day in, day out. It's what we do. And in the UK, the last decade, there's been a big surge. So I would say probably about 50 to 60% of audiologists are now trained in wax removal. And I initially got trained using some head loops. Head loops are similar to like magnifying goggles, essentially. It's what dentists sometimes use to examine inside of your mouth. However, if you've got earwax near the entrance of the ear canal, head loops are fine. You've got an adequate view. However, if the wax is deep in the ear, you simply don't get the depth, you don't get the magnification, and it's just not safe, I don't feel, to remove, or at least with the head loops that I had. I really struggled, and I think a lot of people did, and that's what inspired me to develop something else. And in the UK, all the ENT doctors in secondary care, they use an operating microscope. An operating microscope is a huge piece of equipment. It weighs a ton. It's not portable. And with an operating microscope, although the view is very magnified, and you do get